All right, well, good morning, everybody. We'll go ahead and start this lecture on buprenorphine today. For those of you who don't know me, I'm Dr. Joel Phillips, medical director over at Trinity Health, kind of West Michigan. Clinically, I practice neuropalliative care. So a lot of when you see my face, that usually means we're going to be talking a little bit neurology today, no matter what we're talking about. So today I wanted to focus more on buprenorphine. In the last 10 years or so, this has really become more of a popular medication to be using. This lecture kind of originated from my own fellow lecture back in 2016. So I had kind of decided to look into buprenorphine more myself at that time because it was this drug we talked about, but nobody really knew how to use it or when to use it. So I try to update it every year, so it kind of is an evolving sort of a lecture. And so if you've heard it before, hopefully you'll pick up something new in it this time around. And with that, we'll go ahead and get started. I want to, first of all, thank Dr. Stringer. He showed me this article just published in, I believe it was January or February of this year. So for those of you in the room, I do have printed copies right here by the coasters. So in reviewing this article, a lot of what it says is what was already in the lecture. So 10 years after me, or 8 years after making this lecture, a lot of it was still quite relevant. So I left a lot of that in, but this is from the Pharmacology journal and really goes into a lot of kind of some of the mechanisms, but also a little bit more of the prescribing that I don't go into here. So definitely a good read. And for those of you virtual, I recommend that you track down a copy of this as well. So the objectives today are to understand the contextual history of buprenorphine and then explain the pharmacology and safety compared to other opiates. And then we will go over some of the dosing and typical uses as well. So let's start off by talking about what is buprenorphine. What is this chemical that we want to be using? So first of all, it is semi-synthetic. So it comes from a derivative of the poppy plant. And it's an agonist and antagonist, which we'll get into what that really means in a few slides. It was designed specifically to be a non-addictive analgesic. It's longer acting, anywhere, depending on how you dose it, anywhere from 4 to 6 to 8 to 12 hours, all depending on mechanism. This last bullet, it lists all the ways you can give it, but what's more importantly is what's missing from that, and that's it does not come in an oral form. So you can do transdermal, sublingual, buccal, IM, IV, but there's no oral formulation of this. I just wanted to highlight that this is a Schedule 3 medication. So where most of our opiates are Schedule 2, this one's kind of more on the line of a benzodiazepine. So there's a lot more freedom and flexibility in prescribing as well. So you can write refills for this one, write 3-month supplies, those sort of things. So let's talk about some of the history. So in the 1920s, the scientific community really started looking for a non-addictive analgesic, and it took them 40 years to develop buprenorphine. John Lewis discovered it in 1966 while he was a doctoral student. This is his third attempt at a synthetic opiate. In those phase 1 trials, he actually tested the medication on himself. So third time's a charm. In the 1970s then, so about 4 years or so after it was discovered, it was studied as a possible addiction treatment drug because of the agonistic and antagonistic properties. In 1978, it was approved in the United Kingdom for analgesic purposes, but by the 1980s already, it was being used for addiction medicine. So 50% of the prescriptions in France were written off-label for addiction. And moving forward from there, this medication really found a niche in addiction medicine. So for purposes of today, we are going to be talking more about pain analgesic uses. We won't be talking about the addictive or addiction medicine properties here, but Dr. Poland does an excellent lecture on that later this year too. So let's look at the pharmacology. So again, it's semi-synthetic, comes from the poppy. what I want you to take away from here is it's a full and partial agonist of the mu receptor. So agonism on the mu receptor, but it's an antagonist on the kappa receptor. So when we say it's an agonist antagonist, it's because it's working on two separate opioid receptors, having two separate mechanisms on that front. So let's look at the mu receptor. There's a high potency and it will actually displace a lot of the other mu agonists like morphine. So if morphine's bound to the receptor, buprenorphine will kick it right off. I found in my reading this term receptor reserve. I'd like to learn more about this myself at some point, but some of the literature says that there's only a 50% occupancy rate. So although it binds better, for some reason, there's still opiate receptors that are open for other opiate agonists. Part of that might be because of the second bullet down here. It's also a chaperone ligand. So buprenorphine actually induces mu opioid receptor expression. So the presence of it actually creates more receptors. It's also got a very slow off rate. So it binds tightly and then it's slow to dissociate. When we look at the kappa receptor, it's an antagonist. What we think that does is it reduces tolerance and works as an antidepressant. This receptor is not talked about much, but I think is very important when it comes to to buprenorphine and what it actually does. So this is the OR-like, it's the OR-like, meaning opiate receptor-like receptor. So ORL1 receptor. It's found in two places in the central nervous system. It's found in the dorsal horn, where it has more of an analgesic effect. So this receptor gets stimulated, it's going to modulate that pain, you're going to feel better. But in the
I'm listening to a buprenorphine lecture. It was the fellows.
Anita, can you go ahead and mute, please? In the brain, it inhibits antinociception. So this is about a triple negative here. So what you need to know here is when it's stimulated in the brain, it allows you to feel more of the pain. It's thought to dampen that brain reward system in this way. So we got that inhibitory antinociception. It dampens the reward system, which means there's probably less tolerance buildup because of that. So this one actually plays a big effect in how buprenorphine works. All right. So looking at the pharmacology, I use this just to give an example of where it's working on the three different receptors. So with the mu receptors, it's got full and partial agonism. Part of the full agonism is that it can kick off the morphine that's already on the receptors. Partial, we'll get into a little bit more detail in a second. But then you can see there too, it's got the ORL1 agonism and the kappa antagonism. When we talk about full and partial agonism, this is a theoretical model, kind of proven more in animal models, but there's a lot of merit to this in humans as well, that when it comes to analgesic effects, there's kind of that full agonism where with that dose response curve, the more buprenorphine you get, the more analgesic effect you're going to get. And in theory, you can get up to 100% of that analgesia. When it comes to the respiratory effects, that respiratory depression, there's a ceiling effect. So as soon as you hit a certain point on that dose response curve, you're not going to have any further respiratory depression. So for people who are not opiate naive, for those who are very experienced with opiates, we have much less of a chance of respiratory depression. Now, if somebody is opiate naive and you give them a large dose, yes, there's still going to be respiratory effects. So you do need to watch that as well, but is relatively safer in this regard. When we look at the analgesic effect, this curve kind of highlights that in that first 8 milligrams is where we really have the most effect on analgesia. So when we're talking 8 milligrams, we're talking about sublingual dosing. Just to put that into some perspective for you as well. So if you got somebody on a sublingual 8 milligram tab and they're still having pain, Yes, I have had people go up to 16 milligrams in a day. But usually after that 16 milligram mark, I really I'm kind of leaning towards another medication to help with that pain because you're really not going to get too much more of an effect after that. So when we look more at what happens in the body, it is lipophilic, so it distributes well to the brain, and then it's protein binding. So you get a lot of it bound right to the alpha and beta globulins, but not to albumin. So this really results in low plasma concentrations. In the liver, it is metabolized by CYP3A4 into norbuprenorphine, which we'll talk more about. It's also glucuronidated into these other three metabolites. So you can actually see more of the metabolites in the system than the buprenorphine itself. Importantly, I want you to look at norbuprenorphine, that one and buprenorphine 3-glucuronide. Those have analgesic effects as metabolites. But norbuprenorphine is actually what they think contributes most to that respiratory depression. It does, when we talk interactions, it is metabolized by that CYP3A4 into that norbuprenorphine, or 3A4. But there's no inhibition of the CYP enzyme. So at therapeutic doses, there's few drug interactions because there's no inhibitory effects of that CYP enzyme. CYP3A4 inhibitors do not influence the pharmacokinetics. A lot of that is because it can be excreted in a non-metabolized form. So we're not going to see much effect from the inhibitors. But what you may see is a little bit of competition with other CYP3A4 drugs. So benzodiazepines, for example, are also metabolized by it. So you may see a buildup of the benzodiazepines. You can see more of a CNS and depressant sort of effect. So you do need to be careful when you're using benzos and buprenorphine together. Not that you can't, but just be aware of the potential side effects. This one will be a good table for your reference as you're starting to dose things. So I'm not going to go over this in terrible detail right now, but know it exists so that you can look at it later on. But I just want to highlight here, we can do sublingual, transdermal, transmucosal, and IV formulations. I personally prefer the transmucosal form because it gives us the most flexibility in our dosing and can last for anywhere from 8 to 12 hours, and you get the best bioavailability from it. But of course, because it's the best, it's the most expensive, so we run into a lot of details or a lot of issues with coverage and affordability. If you look at sublingual, you'll see bioavailability is 49% in solution. I went to look this up because it always surprises me when I see that solution. People will actually compound it into a sublingual solution. So I haven't found anything commercially available in solution form. It's mostly in that tablet form when we're talking about sublingual. So let's talk about safety. And now I do have to say I didn't put any disclosures up earlier, but this portion of the lecture, it does tend to sound like an ad for buprenorphine in all the positive benefits from it. So no, I am not. I don't receive any compensation from any buprenorphine manufacturer. So it's just, it's in a sense, we can call it the wonder drug. I don't know. But we've got that ceiling effect on respiratory depression, which we talked about. So of all the opioids, it's safest in that regard. Interestingly, this is more of an interesting fact. It's that norbuprenorphine that they think contributes to more of that ceiling effect. So in one rat model, they actually injected a lethal dose of norbuprenorphine into the rats, and then they counteracted it by injecting your regular buprenorphine, and they found that they could reverse the respiratory depression by giving unmetabolized buprenorphine. So just an interesting fact. When we look at fentanyl, there's a 13.5-fold safety window when it comes to that respiratory depression. So much safer in that regard. We always are concerned about QT prolongation. very safe in that regard. There's not really a very significant QT prolongation until you get up into very high doses. When it's compared to methadone, we're looking very well as well. Like, for example, methadone, I know we usually say that that one does not have much of a QT prolongation. It's usually over 120 milligrams. Buprenorphine in comparison is significantly safer. Torsades are more likely with methadone, where there's already a low risk compared to that buprenorphine. In liver and kidney failure, it's absolutely safe to use. It can be excreted through the bile, so we don't have to worry about excretion through the kidneys. And in liver failure, relatively safe because it can be excreted in that non-metabolized form. In the older population, studies looked at dosing people over age of 65. They found that pharmacokinetics were just the same and did not change with age compared to other opiates where increased half-life is noted. Because of the fewer drug-drug interactions, it's also safer when we're looking at polypharmacy, so we can do much better in that regard. And then I do also want to mention cognitive changes in the elderly population were much less compared to other opiates as well. When we talk about opiate abuse withdrawal, because of the reduced reward response at the ORL1 receptor, we're not going to see as much of that reward response. So withdrawal is less, abuse is less as well. But part of that too, not only the ORL1, but because of its affinity for the receptors, it can actually displace or block that morphine. But if somebody does stop buprenorphine suddenly, we're still looking at, we will go into withdrawal, but it'll be about 3 to 5 days down the road just because of the half-life itself. Low risk of tolerance, slower onset than your mu agonists, but also that ORL1 activity stops that reward response as well. So to put that into comparison, this study looked at people over a 3-month period of time, both patients with cancer pain and non-cancer pain, and they were dosed with either buprenorphine or fentanyl. And what they found is over this 3-month period of time, they just kind of marked what is that dose increase that we need to get to that accurate or that best optimum analgesic effect. And they found a considerable difference between patients on that transdermal fentanyl versus the transdermal buprenorphine, where people needed less of that dose increase with that buprenorphine over that 3-month period of time. In the GI, if you're looking at somebody with pancreatic cancer, just another little nugget to tuck away, there's no sphincter of Oddi spasms. So great for that specific type of pain. And here's what we were talking about with the cognitive, better visual, psychomotor, cognitive function versus morphine, methadone, or fentanyl. And the cognition effect was very comparable to placebo on studies. Post-marketing surveillance, again, this is older data, but they were looking at 13,000 participants in research. And nausea was about 4%, but that dizziness was only 1.5%, and tiredness was less than 1%. And again, could this be related to that kappa antagonism? That's the question that's out there. So let's talk about indications and dosing. So we'll talk about various pain indications, but again, it's used a lot in opiate misuse, overuse. Up until 2022 or so, you needed that X waiver or that special license on your controlled substance license, your DEA license, in order to prescribe buprenorphine for opiate abuse withdrawal or opiate misuse or abuse. But we're not going to talk so much about this indication in this lecture, as previously stated. So where do we use it? I really like this medication for a lot of neuropathic pain. One specific use is central pain syndrome. So when you have an insult to specific areas in the central nervous system, such as the thalamus, and here's my animation here, the ventral posterior medial lateral, let's see, the ventral posterior lateral nucleus of the thalamus, when that gets hit with stroke or whatever it is, it can cause severe pain syndromes where you have severe hyperalgesia, allodynia, pain that's refractory to any analgesic that we have. But buprenorphine can actually do a good job at reducing it, not getting rid of that pain completely, but can have a significant effect on it. Some studies have shown up to a 40% response rate on that buprenorphine with a starting dose. They were using a transdermal dose of 8.7 micrograms. Cancer patients with neuropathic pain, there's a case study that looked at 3 specific patients starting at 35 micrograms, which is the starting dose in Europe for transdermal patches. And they could see that severity rating dropped from that 8 to 10 range down to 3 to 5. And pain is reported more in that satisfactory range. So I just took one of those cases to look at how they were dosing buprenorphine with morphine. So TB is that transdermal buprenorphine, and MF is morphine. So over the course of this patient's care from August to May, they started at that 35 microgram dose, and when they went to 52, they saw that significant drop from 8 to about 5. But as cancer progressed, you can see that they had to continually make changes to both the morphine and the buprenorphine as time went on, but they were able to keep that pain right in that range, usually lower than 5 for most of that duration. Now there was a pain crisis towards the end of this patient's life where they needed to use more morphine, but over time, dose adjusted to the cancer progression, kept pain in that tolerable level. I like this because it also highlights how we can use buprenorphine and a mu agonist together at the same time. There's a lot of myths out there that buprenorphine is that agonist and antagonist, and it must mean that it does something with the other buprenorphine or really mu agonists, but it actually can work well in tandem. When we're looking at opiate-induced hyperalgesia, we know that mu agonists like morphine, particularly in renal failure, we can get the toxic metabolites, which can cause a lot of that hyperalgesia. Buprenorphine is less likely to cause that. And again, that suspected mechanism is that ORL1 receptor. So whatever that receptor is doing, it seems to be doing something well. Looking closer at hyperalgesia, this study took healthy volunteers and gave them electrical shocks. And then they were administered various combinations of buprenorphine with placebo. But what that actually looked at was they studied where the effects were the strongest, and they found that the anti-hyperalgesic effects were stronger than the analgesic effects. So yes, buprenorphine provides analgesic pain relief. It also helps with a lot of that hyperalgesia. So that small sort of pain, like a pinprick with hyperalgesia, may feel like your entire arm is on fire. So hyperalgesia is really just the magnification of a pain nociceptive response, whereas that allodynia, which we talk about sometimes, is really that abnormal pathologic pain response to something that's non-nociceptive, something like sleeves on your shirt, wearing socks with neuropathy, bed sheets on your legs. That's more of that allodynia, just to kind of clarify the difference between the two of those. Taking this hyperalgesia a step further, this study looked at how buprenorphine does compared to other medications when we're looking at that analgesic response and that anti-hyperalgesic response. And buprenorphine is comparable to S-ketamine in that sense. IV is a little bit better than sublingual, but when you look at fentanyl as a mu agonist, you see more of that analgesic response, but it's that anti-hyperalgesia, which really, I think, helps us when we're looking at more of that neuropathic pain. Now, I do wish that this slide compared it to ketamine. That would be an interesting study too that I haven't dived into, but. So when we look at these curves here, this is just to emphasize again, I just took a line at 50% and you can see that blood concentration to get 50% pain relief is at about that 0.3, where the blood concentration to get a hyperalgesic response is at about 0.1. So it's a steeper curve to get that hyperalgesia under control compared to that pain. We can use it for chronic somatic pain. One study showed 85% of patients reported good to very good response, with a 48% reported improved quality of sleep. Pain can be equally or slightly better than morphine, fentanyl, or methadone, especially when we're looking at pain beyond that 1 month mark. We see that buprenorphine can be more efficacious than morphine. Compared to morphine, it's 33 times more potent and has 50 times more of that higher affinity. One meta-analysis looked at buprenorphine for acute pain, or buprenorphine versus that morphine. It's got a slower onset, but by that 1 hour mark, it's just as effective. And then when we're looking at the trends towards better analgesia, after 1 hour, it was trending towards better pain relief, but was not clinically significant. So it is something that you could consider for that acute pain setting as well. Looking at some of the side effects, this study looked at sedation specifically. There was no, the overall odds ratio there at the bottom, you can see that it crosses that midline. So there's no significant difference, but a trend towards less sedative effects. I do question when we talk about sedation. You've heard people talk about it before. I gave the patient morphine and it just made him too sleepy. It knocked him right out. But oftentimes that's because the pain's relieved and it's finally relieved and patients can get some sleep. So that's my question with this study, is what was reported as sedation. Was it truly sedation, or was there this effect of we were getting that analgesic relief and we're finally able to rest and let the body catch up on sleep? When we look at respiratory depression, again, we've got that this one kind of highlights that it may be more of a theoretical ceiling effect. Again, there's a trend towards safer in respiratory depression, but we can't necessarily say there's a significant difference based on this meta-analysis. So it's good to still monitor closely. We do see that overall we're going to be in kind of trend towards that safer response. But again, my bigger concern is for people who are opiate naive, we may see more of that respiratory failure and respiratory depression really kick in. So again, this is just a highlight or kind of repetition of what we saw earlier. So this, I want to thank Dr. Emery for this slide. She came across this a couple years ago and has really been the best conversion table that I've seen myself. So that top row is the oral morphine equivalents in 24 hours. So 12, 24, 48, et cetera. And then you've got all the different forms of buprenorphine before that. You've got the transdermal buprenorphine, buccal, and then sublingual. Looking at transdermal, in the United States, we start at 5 micrograms an hour. And these are patches that you use you change them out weekly. So every day or once a week, you just change the patch. But we start at 5 and we go up to 20. So that 5 is really about an equivalent of 12 oral morphine equivalents, and 20 gets you up to that 48, 60 realm. But without adding multiple patches, you can't get much higher than 60. Now compare this to Europe. Their patches start at 35 and go up to 140. So there's a lot more leeway to use transdermal patches for a good analgesic effect. Now I have used on occasion 2 of the 20s or that sort of thing. So that is a possibility to do to get to those higher doses. I'm going to skip over buccal for a second and go down to sublingual. What I want to highlight here is 1 milligram BID is about equivalent to 80 to 100 oral morphine equivalents. And the tablets start at 2 milligrams. So to get to that lowest equivalent of 80, you're looking at cutting the tablet in half, or using just one tablet in daily. Tablets don't cut in half very well. Patients tell me they crumble. So you don't really you might not get the good effect that you want to. So I don't tend to start people on sublingual because it's such a high morphine dose. I may do that if they're already experienced with opiates and have built up some sort of tolerance already, but not a good one to start people on. When you look at that 2 milligrams TID, we're already looking at that 300 oral morphine equivalents. I will say that I do have some patients on 8 milligrams twice a day. So some people we do need to get pretty high before they get that relief. And it's in the right patient, it can be safe to do. But the buccal patch is really my favorite. This is a patch you can use once every 8 hours to 12 hours is what I typically dose it. That 75 microgram patch, well, any of the patches, but that 75 microgram, you can even cut that in half. So you can use it as a 35 microgram patch, starting with a very low oral morphine equivalent. That gets you down into the single digit range. And you can move all the way up. Again, I've had people on 450 micrograms 3 times a day. So I have patients run the gamut, but this one really allows you to titrate the best and get that optimal dosing for your patient. Recently with the sublingual and a little bit with the buccal, you'll see this. You do have to worry about tooth decay. So often after using sublingual or even the transdermal, it's recommended that people do rinse. Wait a little bit before brushing your teeth, but after about 20 minutes or so, should probably brush your teeth. Let it soak in for a little bit before you go ahead and do it. But
Where do you put the buccal patch? Is it like right inside?
right inside the mouth. So again, I don't do much with IM or IV, but it is available and it can be effective for 6 hours. Sublingual comes in that 2 and 8 milligram tablet form. Takes about 10 minutes to dissolve. Subutex was the brand name. Typically it's recommended for breakthrough pain, not for maintenance. And that's a lot of because of the risk of the oral ulcers and now the tooth decay. But the reality of the situation is that sublingual tends to be the cheapest, most affordable, easiest covered by insurance. So it may be one of your only options to go to. So I do have a fair number of people who are on it on more of that daily basis. Transdermal, again, we talked about the availability in the US and Europe. Diffuses directly into the systemic circulation. So unlike fentanyl, where we build that depot, that fatty deposit, this just goes straight into the bloodstream and you're good. So advantage, no peak or trough effect. Buccal films, again, 75 to 900 micrograms. Again, the beauty is you can cut them in half. Once you hit that 900 microgram point, you should start to be concerned a little more with that QT prolongation. But that's a very high dose. I don't think I have anybody on a dose that high. So when we're starting the dose for patients, if somebody's opiate naive, transdermal, you can do 35 to 70, good place to be. But even with somebody naive, you can start them at that 20 microgram an hour patch. The problem is you can't go higher than that patch. So that you're starting at that highest available dose we have. Buccal, again, 75 to 100 may be a good place to start. And then sublingual, do avoid 1 milligram BID. You could put your patient into the hospital with respiratory failure. So as small as 1 milligram sounds, it's at quite a high oral morphine equivalent. So again, there's no ceiling effect on that analgesia. Some case reports have shown that patients found pain relief as high as 7 milligrams IV. So when we're looking at the IV dosing, we're talking about 0.3 to 0.6 milligrams as that starting dose. So getting up to 7 milligrams is quite the achievement. So the question always comes, you're on the inpatient service, palliative care, they consult you, surgeons consult you and say, this patient's coming into me on buprenorphine. What do we need to do with that? Please help control the pain. So what needs to be done for patients who are on a Butrans patch or other forms of buprenorphine prior to surgery? Oftentimes you'll hear people suggest removing the patch prior to surgery due to the quote unquote antagonistic effects. Is there a reason for this? And this is where I can poll the audience. What are you guys thinking? I'm hearing no, because
You said little interactions with other meds, right?
little interactions with other meds. No, because the antagonistic effects are, as Kara pointed out, on the kappa receptor, not on the mu receptor. So it's safe to use. So there's no antagonism in combination with that pure mu agonist, both because of the what Matt had said, but also because of this kappa antagonism. So what do we do in acute pain for somebody who is on buprenorphine, post-surgical pain, other sorts of acute pain? There's 4 different recommendations. We'll go through all of those, but number 1 is really the simplest and easiest and the one that I would recommend. So that is really, don't change your maintenance dose. You can titrate short-acting medications to higher doses, but keep them on that home dose of buprenorphine. Just kind of let it ride where it is. You might see some increased sensitivity to those full opiate agonists. So you do need to watch sedation and respiratory depression when you're using these medications in combination. But if we're sticking with short-acting doses, we should be able to monitor that closely and hold medications or change doses of those short-acting mu agonists as needed. Some people will recommend you could divide, so take that daily dose of buprenorphine and divide it over 6 to 8 hours. People may be doing this, say we got somebody on a transdermal patch and now they're coming into the hospital. They may decide to do it this way. You can add the short-acting medications or opiates for breakthrough. It's just one more option, but I tend to go with simpler is better. And that first option of just keeping their stuff, their same dose consistent is probably best. But for whatever reason, if you don't have the medication available, you can discontinue it, but start a rapid titration of long and short-acting full opiate agonists. So you can transition them over relatively quickly to like an MS Contin with short-acting MSIR or something similar if needed. Others recommend converting, change that buprenorphine into methadone about 30 to 40 milligrams daily. Methadone binds less tightly, so you get more of a predictable response from your mu agonists. So all of these are viable options and may fit in the right circumstance, but typically I'd start with number 1. So looking closer at buprenorphine and mu agonist, as we've talked about through this lecture, it's safe to do. Buprenorphine's occupying fewer of those receptors, and it increases expression of the mu receptors, but you do need to use caution. Particularly with morphine and tramadol, you can see more of an additive effect, whether that's synergistic or other reasons. There might be more clinical potency to those medications. Dilaudid and oxycodone, we might have even a stronger effect. So opiate use is recommended for breakthrough pain, and it shouldn't be avoided. These can work well in tandem. When we look at products that are out there, you may hear these terms thrown around. Butrans patch is the commercially approved brand name patch. We do now have generic forms. Unfortunately, generics, even with copays, can still be a couple $100 a month. So it's available, yes, but still cost can be prohibitive with that. Buprenorphine is another brand name, and then Subutex is the brand name of the sublingual tablets. And what I want to highlight with Subutex versus Suboxone, Subutex is just the buprenorphine. So when you're in the hospital, Trinity has Subutex or just the transdermal or just the sublingual buprenorphine tablets, 2 milligrams. You can also order Suboxone, which is the buprenorphine and naloxone. So they are two separate things. This used to be a bigger deal, and when we had the X waiver, because without the X waiver, you really ran into more issues with prescribing the Suboxone because that's intended use was more for opiate misuse disorders. And Subutex is more for pain and palliative. You can use them interchangeably. Just know that naloxone is part of that Suboxone brand. Just as an aside, do you guys know how that buprenorphine naloxone works in Suboxone? Why those work together and why we have that effect? I'm getting a no from Kara. No from David.
Well,
Anybody else on the call? Okay. Well, good. This is a bonus learning experience today. So let's think about the mechanisms of naloxone. What is the oral bioavailability of naloxone?
Poor.
Very poor. How are we normally administering naloxone?
nasal spray or IV.
IV. IV. So naloxone is IV administered. So naltrexone, we can use orally, but naloxone is IV administered. So why would we put naloxone in a sublingual tablet?
To prevent people from shooting up with dissolving it.
Exactly. So it's more as a tamper-proof or
Tampering.
it's more tamper-proof. So if you're taking it sublingually, you're getting the effects of the buprenorphine. You're not getting the effects of the naloxone. But if you were to take the tablet, crush it up and try to inject it, suddenly that naloxone's getting into the bloodstream and you're knocking all the opiates off the opiate receptors and you're going to go into withdrawal. So that's why Suboxone works how it does, is that combination of naloxone keeps people from using it the wrong way. So just cost comparison, I looked this up a couple days ago. Sublingual tablets, if they're not covered by insurance, can still be relatively expensive. If you compare this to like a morphine may be just a couple of dollars. So it's expensive. Some people may be able to afford it out of pocket, but most of the time we are able to get this covered by insurance. Buccal films, even at that mid-range of the mid to low dose range, we're still talking about $477. So that would be a monthly cost if you're using it twice daily. So that's less affordable and can really eat into somebody's savings. Insurance doesn't typically cover this one very well, even though it's my favorite one to use. And then with those transdermal patches, prices come down a little bit since they become generic, but we're still looking at 4 patches can cost about $200 a month. So this is not an inexpensive medication, unfortunately. I'm hoping with the popularity it's gaining and kind of both clinically, but also kind of more politically, maybe we can see changes in this in the coming years. But for now, just keep that in mind as you're dosing these for patients. So in summary, it is a long-acting semi-synthetic opiate. Typical administration, again, is not orally, but is either sublingual, buccal, or transdermal. Can be an excellent one for neuropathic or somatic pain. And it really does have that great anti-hyperalgesic effect. So it can be very good as another medication to consider when you're looking at neuropathies or other sort of neuropathic pain. It is appropriate to use pure mu agonists for that breakthrough pain. And it is safe in liver and kidney failure and can be safer than traditional opiates with that relatively less respiratory depression and little risk of QT prolongation at the normal doses that we're giving. So with that, I will open it up to questions.
So Joe, I just want to make sure I'm clear on this.
Mhm.
So the reactivity to other meds is low and it has neuropathic properties. So are you using it in combination with let's say you have MS Contin, you're using, as your daily kind of maintenance drug? Do you use it in combination or are you using it essentially as the med by itself?
In my practice, where I see a lot more of that neuropathic pain, I'm using that as the med for that neuropathic pain.
Okay.
I tend to avoid opiate medications when it comes to that, just because we don't see as good of an analgesic response in general. I don't know
You have both.
if you have more of a somatic pain.
You have somatic and you have neuropathic. Say you have a diabetic patient that has foot ulcerations, neuropathy, and
I personally would tend to just keep dosing up that buprenorphine.
okay.
I don't know if there's much. I haven't had much experience myself in doing a long-acting buprenorphine with a long-acting pure opiate agonist. Not much that I saw in literature as well. I think I'd just stick with one to be more of the long-acting one. And I'd dose up that buprenorphine to keep things kind of at baseline running in the background and then use more of your short-acting mu agonist as that breakthrough pain. As that rescue med.
In seeing patients with those severe neuropathic pain syndromes like thalamic pain syndrome, coming to you on other neuropathic pain medications like gabapentin or pregabalin, amitriptyline, how do you take them off of those medications to start something like this? Is it bringing down the dose and adding buprenorphine, or how do you manage that, like polypharmacy and some of these patients who've tried everything?
Yeah. Typically, I'll keep them on their gabapentins and their Lyricas at least short term, because even though it's not providing 100% relief, patients will come in, tell you that the gabapentin's not working. You take them off the gabapentin, and the pain's considerably worse. So I tend to leave them on as I start the buprenorphine and get the buprenorphine more of the pain, and then we can talk about the role of that gabapentin or Lyrica and whether that's something that we want to come off of. Oftentimes there's the side effects, sleepiness, somnolence, so people are ready to get off of it. And then we can kind of build one up as we take one off, but I'll usually start the buprenorphine before considering that. Other questions?
So
buprenorphine is a medicine that I really like to use on the adult side. Trying to translate it back to the pediatric world, I feel it's a medicine that they haven't used much and are uncomfortable with. Do you have any recommendations or any experience with the initiation of buprenorphine in our pediatric patients or opioid naive pediatric patients? I feel like a lot of our cancer patients would have neuropathic pain from that, so it would be a great one to use, but it's just the inexperience with using it in pediatric patients is one that shied away from you.
Yeah, no, that's a great question. I don't do too much with pediatrics myself. I would tend to try to use the lowest dose possible. And if at all possible, I know it's peds, getting that buccal patch to stick sticking your finger in their mouth, kind of putting it on the side of their cheek. I'm not sure how cooperative patients might be in that sense, but that would really be the best way to titrate. But beyond that, I don't have a good answer for it. Brad, I don't know if you're on the call or not, or if you tend to use this at all in the inpatient setting or in the ped setting, but it may be harder to administer in general.
Hey, Joel, this is Sandy. Brad, I don't know. Well, Brad is currently out of the country in a different time zone by several hours.
Right.
So that would be
Oh, good.
something if he popped on. I didn't,
Yeah.
but we as Sammy asked, I'm so glad he did. I think nationally for pediatrics, buprenorphine, if it's being used, is episodic, and for like niche patient populations. We mutually cared for a patient along with U of M who had sickle cell, and they started buprenorphine for him there, and we continued that medication here. But that's an N of one so far for us. But I think that it is gaining some momentum. Methadone seems to be preceding its excitement, and that's actually kind of coming our way more so for acute pain management in a new way. But like Sammy echoed, we'd be very interested to try to figure out and learn more about its its support in pediatrics.
Yeah. Yeah, no, I'd be really interested to see where we could go because I can see its use. My biggest concern again would be how do we get it in?
Right. I
But-
think, Joel, maybe since I have the microphone real quick and we can take this offline, but I saw in one of your conversion slides that reference for formation of IV in our Corewell, like our peds pharmacy team is trying to do a broader Epic build out to help increase our capacity of using. We have some limitations with just how the pumps are programmed here and how our Epic is built. And frankly, it limits our use of maybe a lot of the more familiar opioids, and methadone isn't even built into our PCA. But do you have any experience with IV buprenorphine?
I've tried it once or twice on the inpatient side. It may be great for those acute sort of pain situations, but like anything, we got to figure out what is the plan going home afterwards. So getting them transitioned to something else would be appropriate. So because of that, I haven't dived too deeply into the IV, but it definitely would remain an option. But Sandy, you bring up a good point because with ketamine, we'll often dose kind of ketamine orally, the IV ketamine orally. I wonder if that's a way, if there's any way we could do like a sublingual IV dose just to help with administration. Just thinking outside of the box right now, not my medical recommendation by any means, but talking with a compound pharmacy too, getting it into that oral sublingual, that solution that first table I mentioned, may be something that would be more of a viable option in that pediatric world too. But thank you. That's a great question. I think I'm going to have to add a section to my lecture for next year, pediatric administration.
Oh, Joel, that'd be great. Thank you.
So to clarify then, because it has a full mu agonism effect, like it should not, if you're transitioning from another opiate to buprenorphine, it shouldn't also initiate like a buprenorphine with initiated withdrawal, or is that kind of more about a myth, or is that
I'd say if you're doing it under supervised circumstances, it shouldn't create withdrawal. There's people will talk about how adding buprenorphine will kick all the morphine off and then people will go through withdrawal. I haven't personally seen much of that myself. I think it's more of a theoretical risk. But if you think about the mechanisms again, you're kicking that the buprenorphine is kicking the morphine off. It's providing some analgesic effect, but that other morphine is free to hit the other open receptors that are there. So I can't imagine there really being as much withdrawal as people are worried about.
Joel, do you mind if I chime in with that point?
Yeah, go ahead, Garrett. Mm-hmm.
So the answer to that kind of depends as well too, because in an extreme example, any patient on more than 50 to 80 OMEs of full agonist opioids, if you were to put them on a full dose of buprenorphine, let's say 8 milligrams BID, you would definitely precipitate withdrawal in that circumstance. So I guess the take-home point to remember is with patients on 50 to 80 or more OMEs of full agonist opioids, that would be an indication to do a buprenorphine microinduction and to introduce buprenorphine slowly over the course of 5 to 7 days versus starting a higher strength buprenorphine that would correlate with the OME similar to what we would do a normal long-acting initiation. So just remember patients on more than 50 to 80 OMEs to consider a slower initiation of buprenorphine. However, in another circumstance, if they are on a higher dose full agonist OMEs and you just started a 10 microgram buprenorphine patch, you absolutely wouldn't precipitate any withdrawals and they'd be able to tolerate that very well. Or even a low dose of Subutex or Suboxone, like 1 milligram, shouldn't be enough to precipitate withdrawals in those circumstances.
Thank you for that insight, Garrett. I'm curious now, can you explain that a little more? Is it more because we're seeing more of the receptor saturation at those higher doses, or do we know a mechanism?
Yeah, that's exactly the answer. With the full dose, with the 8 milligrams BID of buprenorphine, we're saturating the vast majority of our opioid receptors, thus the greater probability to displace our full agonists. For an example of oxycodone, buprenorphine binds 120 times stronger than oxycodone to the mu opioid receptor. So we can imagine if we had enough to saturate 100% of those, we could definitely precipitate withdrawal, specifically with oxycodone pretty easily. But yeah, I think it's because of the percentage of receptors that can be saturated by buprenorphine versus the other extreme example. If we just started a 5 microgram per hour buprenorphine patch, that would saturate a very, very, very low amount of the opioid receptors and would have a low probability of displacing our full agonists.
Thank you for that. That makes a lot of sense.
Absolutely.
All right.
Hey, Joe, can I just go back to one?
Yeah, go ahead.
For one question. So do you know if like insurance at all, like Medicaid picks up for this or no?
It's
Because with kids, a lot of them are on Medicaid, for instance.
that's
That would be an option, but they're not going to pay $400, $200.
well, that's the funny thing is if we're talking about Medicaid, there are specific Medicaids that actually pick up the transdermal or the buccal patches. Like the one insurance you don't think would cover it
It does.
is the one that does. So it's always worth running through insurance to see what's covered and what's not. So, and the VA, they do a great job of covering it too. So if you've got somebody with VA benefits, that buccal film may be a better option or a more realistic option. Any final thoughts? Otherwise, we can go ahead and transition to the case. I appreciate the conversation we had today. And if there are other questions that come up, feel free to text me, haiku me, email me. I respond to most things. So thank you, guys.